consumers to look at it, and don't they need to do the research and find out, okay, this is fresh, this is not, the difference between canned and fresh. You've got to learn that difference.
Yeah, you're getting a lot more vitamins and minerals, much healthier going for these fresh vegetables.
Okay, fruits are up next. Any fruit or 100% fruit juice counts as part of the fruit group. Fresh, canned, packed in 100% juice or water, frozen, dried, maybe whole, cut up or pureed. I think that right in there is packed in 100% juice or water, because don't you also find things that'll come out and talk to themselves about fruit juice? But if you look on it, I saw this the other day in the store. It said fruit juice, but on the label it said 40% fruit juice.
Yeah.
You have to look at what else is in there, yes?
Yeah, absolutely. You want to make sure what you're getting is actually the fruit and you're not getting something else into your body.
You're getting, again, it's a lot of sugars that get thrown in there as well. I would guess that's the biggest issue too. And then there's dairy, which is very important, milk products, foods made from milk considered part of the food group. Switch to fat-free or low-fat dairy products that are high in calcium. And again, stay away from non-processed milk. We talked about that earlier in the show. Make sure your milk is pasteurized.
Right, the milk is pasteurized. It's very important, again, for listeria. And calcium. Calcium is very important. A lot of women are not getting their calcium, and this is important for your bone health. As the baby is growing, if you're not getting calcium from your diet, they're going to get the calcium from your actual bones, and you're going to be increasing your risk for osteoporosis later in life. So we can get calcium in supplement forms, and we do recommend that. It's in the prenatal vitamins, or you need to take an extra calcium on top of that, but the best source is going to be that dairy.
And then there's protein. This is another one of those simple things. Lean with the protein. Low fat, lean meats and poultry. Vary the routine. More fish, nuts, seeds, peas, and beans. But again, be certain about, we talked about this earlier, be certain about the kind of fish that you're eating, and not every single piece of beef that's out there is something you would recommend, I would guess. You have to be, again, very, very judicious in what you eat.
Right, the beef, you want it to be cooked well. We're avoiding the raw. And fish, again, we're avoiding the high mercury fish, but again, fish is so healthy, so you want to get that message across to our women planning pregnancy and the actual women who are pregnant that fish is healthy, eat it, but make those wise choices.
And a lot of this is keeping your baby healthy. We want to make sure that birth defects stay out of the mix here. We have a short video here that further explains what causes birth defects, so listen up and pay attention to this.
We know the cause for some birth defects, but for most, we don't. That's because we think most birth defects are caused by a complex mix of factors. There are some factors that can increase the chance of having a baby with a birth defect. These are called risk factors and include smoking, drinking alcohol, or taking certain street drugs during pregnancy. Having certain medical conditions, such as obesity or uncontrolled diabetes. Taking certain medications, such as some acne drugs. Having someone in your family with a birth defect. Being an older mother, typically over 34. And exposure to some chemicals and viruses during pregnancy. Having one or more of these factors doesn't necessarily mean your baby will have a birth defect. It is important to talk to your doctor about what you can do to improve your chances to have a healthy baby.
What is the discussion like when you have a woman who comes in, well, the family, the woman, the husband, partner, whatever it is, when you start talking about pre-pregnancy counseling? I mean, that's always got to be recommended. So I would imagine that a lot of what we just saw there is involved in that, but what else is in that?
I wish all my patients came in for pre-pregnancy counseling. Unfortunately, a lot of pregnancies aren't planned. So that pre-pregnancy appointment is great, and you can go over all these factors, and you talk about their history and what can put them at risk, their medications, you go over their vaccinations, their ethnic backgrounds, all their screening, but it's not always planned. You talk about taking their prenatal vitamins, that they're getting their folic acid, their omega-3. Fortunately, a lot of foods today are fortified with folic acid because so many pregnancies aren't planned.
What about the supplements? Because there's 1 million to 10 million of them out there. And I got to imagine that a lot of them will market and sell themselves as, you've got to have it, top supplement, must have this. They're not all necessary. Isn't it fair to say that you've got to teach people what you need and stay away from what is basically fluff that your body just doesn't need?
And not only doesn't need, there actually are some things that can be harmful in pregnancy. But what's most important for that pre-pregnancy, that planning, is the folic acid and the omega-3 fatty acids, the DHA. Both of these have been shown to actually be beneficial for pregnant women. Folic acid decreases a neural tube defect, spina bifida. This is why a lot of the foods are actually fortified with that, because of all those unplanned pregnancies. Not everybody's so fortunate to be taking them. And then the omega-3 has been shown to be good for the brain development of the baby. And nobody wants not to get that advantage.
How do you take, boy, here's a loaded question. Because again, you're part psychologist more than anything else. This is a very stressful time, whether you have a family unit sitting there or somebody with an unplanned pregnancy. How do you deal with that? How do you start that conversation? And how do you as a doctor get close to them, get them to trust you, but also try to pull some of that stress out?
It's always a very stressful time. But you go through all their concerns. You talk them through what they're concerned about. You educate them, and you go through this pathway together.
When you have that, you said earlier you wish every patient came in and talked about planning and did a lot of these things. Is there a rising awareness? I mean, are there now, do you see more women out there, more families that are coming in that want that pre-pregnancy planning, that want to know more about their nutrition? Because sometimes it seems as if some people aren't listening. In my patient population, I do have a lot of patients. They come in specifically for that appointment to find out what they can do. They want to be educated. What tests do they need to do? Their vaccinations. What medicines are they taking that could be a problem? Should they be taking a different supplement? And that's a breath of fresh air. And when you get that breath of fresh air, I mean, look, you've been doing this a long time, but just to be able to know that you're imparting some knowledge here that can create a healthy life in the world. I mean, I'm asking you now from the heart, from more than just the doctor. That's got to be an emotional moment there that tells you that you're part of bringing a healthy life into the world. That's a huge responsibility.
Yeah, absolutely. And then they call in a couple months and they give you that great news that they're pregnant, and you know you're going to be a part of that great part of their life.
Do they come back? I mean, did you get to see a lot of your patients when their children were older? Do you stay in touch with them? Or?
Oh, absolutely. I'm taking care of a patient now. I delivered her, so that's great.
And she's how old now?
She's 16.
She's 16, and you've been having her whole life. I mean, that's just, what you do is brilliant. And to those of us who are not medically inclined, just you're taking that life from conception right to that point. That's wonderful. Thank you very much, doctor. We really appreciate you coming in today.
Absolutely, my pleasure.
Wonderful. Take care of that baby, please. All right. So, all the time we have for now, but be sure to join us next time on the Health Channel, All Health All the Time. And don't forget, visit the website, allhealthallthetime.com. Questions, submit them for the experts. We'll learn more about the Health Channel right now.
Every year, millions of Americans are exposed to a contagious virus.
What is this virus? It's stigma.
Stigma promotes an environment of shame,
fear, and silence,
which prevents millions of people from seeking help.
But there's good news.
The National Alliance on Mental Illness believes stigma towards mental illness is 100% curable.
So do yourself and everyone a favor.
Go to curestigma.org and get tested for stigma.
Don't just worry about your health problem. Ask an expert. An answer to your health question is as close as your phone. Call 855-796-4475. The Health Channel, America's first all-health, all-the-time TV channel. Fully qualified health experts, doctors, specialists can answer your health questions. The Health Channel, all health, all the time. Call 855-796-4475.
really talking about when we're encouraging people with arthritis to be more physically active is doing moderate physical activity like walking, swimming, biking that get their heart rate up a little bit or get them breathing a little bit harder.
Aim to do moderate physical activity 5 days a week for 30 minutes a day. Exercising as little as 10 minutes at a time will allow you to achieve the recommended 2.5 hours per week and get real health benefits.
You want to listen to your body so that if you're too sore, a couple hours later you know to cut back, maybe do a little bit less duration or frequency.
It's not running a marathon. It's not the no pain, no gain idea. It really helps reduce some arthritis-specific symptoms like pain, swelling, limitations. Things like fatigue and depression also improve with physical activity.
It is the most amazing gift that you can give someone. Seeing individuals have an opportunity with their lives that they would never have again.
The Health Channel is made possible by the continued leadership and generous support of the Eunice Joyce Gardner Charitable Foundation and the Kessler Family Foundation.
Welcome to the Health Channel, all health all the time. I'm Olga Villaverde coming to you from the Baptist Health South Florida studios. Breast cancer is one of the most common concerns found in women. In fact, 1 in 8 women will be diagnosed with breast cancer. But the good news here, and this is the best news of all, the survival rate is wow, 98% if it's detected early at a localized stage. That's fantastic, 98%. Joining us today to talk about breast health and breast cancer screenings is Dr. Priyanka Grover, breast imaging radiologist with Baptist Health South Florida. Welcome, doctor.
Well, thank you.
Thanks
Good
for being
morning.
here. Really important to talk about this Breast Cancer Awareness Month, so it's an important month for all women. Doctor, first, before we talk about breast cancer as a whole, diagnosis, what women should be doing today, let's talk about you for a second. You're a breast imaging radiologist. Can you kind of give us the ABCs of that?
Sure. I'm a radiologist and I specialize in breast imaging. Basically what I deal with is mammograms, breast ultrasound, breast MRIs, procedures like breast biopsies and pre-surgical needle localizations. As a radiologist, I feel that this field is great and there is less awareness about breast cancer screening, which is unfortunately very common in the United States. 1 in 8 women will be experiencing that in their lifetime, unfortunately. So yeah, I feel very happy that I'm part of breast imaging and I'm here today to talk to you.
That's right. We're going to create that awareness of how important it is to get those mammograms and an ultrasound if you're like me, which I'll explain a little bit later. What is your relationship between let's say other physicians and yourself? Because it's not just OBGYNs anymore. You know, primary care sends patients to you. The whole gamut.
Absolutely, absolutely. So basically, we deal with every field of medicine. We deal with OBGYNs, family practitioners, plastic surgeons, and pretty much every field. Sometimes we even deal with pediatrics because pediatric patients develop breast after 14. So, I mean, roughly around that age. And we help screen, diagnose, and do pre-surgical management in case of any breast abnormality.
All right. I want to do a little bit of a show and tell with our viewers. So if we could take that 3D image that we have right now of the breast, and it's a side view, I believe. Yes, it is. So, doctor, tell us first of all what we're looking at, and then I have some more specific questions as to what is happening when breast cells are present in the breast.
Sure, this is a great illustration for breast anatomy. So basically what we are looking at right now is breast is made of fatty tissue and glandular tissue. So as we can see, there is a tail of fat going into the axillary region. We see these small almond-shaped lobules, which are also known as the glandular tissue. They produce milk. And then there are ducts. Ducts primarily are for biological purpose and for breastfeeding, transport the milk to the nipple. Now, cancers may develop within the ducts or lobules And those are the areas which we screen during when we do mammogram and ultrasound. We are taking a closer look of the ducts, lobules, and the breast tissue here. As we can see that this illustrates if the stage 1 breast cancer is pretty much confined within the this tissue, and once it starts growing beyond, then it advances in the stage. Here we're looking at a cluster of breast tissue, basically cancerous tissue, growing beyond the lobule and invading the surrounding breast parenchyma. There are also these green channels are basically lymphatic channels which normally drain the lymph from the breast parenchyma to the axillary lymph nodes and to other lymph nodes above the axillary region. Cancer cells can also go beyond these lymph node channels and can get advanced to the axillary lymph nodes or further lymph node levels.
All right, and then we always wonder, you know, who is at risk for breast cancer. We sometimes hear if you don't have family history, you should be okay, but I know of a few people that didn't have family history and unfortunately were diagnosed. But there are some basic risk factors. Let's show them to you and walk you through them. Gender, that's a big one. Age.
Correct. So in advancing age, the cancer risk goes higher.
Okay. Inheriting certain genes?
Like BRCA.
The BRCA.
Yeah, exactly.
That's the BRCA. Okay. Yeah. Race? Race is one?
Correct. So, well, Caucasian women get affected with breast cancer more often. However, African American women experience more severe or aggressive type of cancer, unfortunately.
All right, family history is always up there. Personal history, dense breast tissue. That's me. When I go to get a mammogram, I always get that look from the individual who's doing it, and it's this face of, oh my gosh.
Yeah.
But they're extremely, extremely, extremely dense.
Yeah.
And, well, the good news is, you know, they're still perky. I guess I could say that, right? That's the good news. So they're still perky. But the bad news is what?
So dense breast tissue, or women who have dense breast have higher rate of cancers, some studies have proven. In addition to that, they are harder to diagnose given the fact that they are so dense. So only based on a 2D mammogram, sometimes it's really hard to see through. So we have tomosynthesis, which is great for dense breast tissue, which helps us see through it. In addition, we use breast ultrasound, which is a great screening tool if we need to find if any masses or any findings which are not easily sometimes seen in the mammogram only.
Exactly.
In dense breasts.
So if you have dense breasts like me, get that ultrasound, and that's what I usually follow up with. Atypical breast lesions, early menstruation, and late menopause. We have a few more. Drinking alcohol, being overweight or obese. I was surprised about that one. Physical activity?
Correct. So if you, studies have proven if you work out 4 to 7 hours a week, that decreases your risk of breast cancer.
Okay, fantastic. Having children, birth control, hormone therapy after menopause, that we've heard so much where so many people don't know whether they want to take that or not. Breastfeeding. Now that one I have to ask you about.
Sure. So breastfeeding actually is protective against breast cancer. So the more you breastfeed, especially if it's longer than 1 year, it offers protective mechanism because your breasts are not exposed to the regular hormones which a woman would be exposed in her lifetime.
Okay. Now, we mentioned the BRCA gene mutation. Can we explain that a little bit, doctor, for those that maybe don't know what that is?
Sure. So BRCA gene mutation, there are two types which we talk about mainly, BRCA1 and BRCA2. If a female has been diagnosed with BRCA gene, she's at increased risk for breast cancer and ovarian cancer. And unfortunately, there is 85% lifetime risk of developing breast cancer in her lifetime, which is pretty high.
That's pretty high.
So undergoing a genetic test, if your family member has ovarian or breast cancer, especially sister or mother, if you have a family history, then undergoing a genetic test or undergoing a genetic counseling and possible testing is a good idea. Talk to your doctor about it.
Absolutely. Always discuss it with your doctor. Now let's take a look at this short clip further explaining the BRCA gene when there is a mutation or a change. Take a look.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Now, before we go to the break, I want to go over some myths that a lot of us hear that get us a little bit nervous, and I just like to go over them because, boom, you think you have it and it's not even true. Number one, most breast cancers run in families. True or false, doctor?
No, actually 70 to 80% of the breast cancers are spontaneous. They don't have any family history, and they are just due to chromosomal aberrations and other causes, some unknown causes.
Okay. Number two, there is nothing you can do to lower your risk of breast cancer.
No, that's not true. Of course we can do. We can adopt a healthy lifestyle, including healthy diet, exercising regularly. We can lower our BMI, body mass index, and decreasing alcohol intake is actually a great tool. The studies have proven the increased alcohol intake in women actually predisposes them to risk of breast cancer.
Okay, number three, it's hard for me to even read this. Bras cause breast cancer.
Well, you'll be surprised. A lot of patients ask me this question, that bras wired bras can cause breast cancer. There are no proven scientific studies to say that, to confirm that.
All right, good. So we already know that. Checked off. And last one, antiperspirants cause breast cancer.
No scientific data to support that. Deodorants or antiperspirants or any other type of zinc or aluminum containing perspirants have not caused any scientific proven breast cancer.
All right, great information. Stay right there, doctor. We're going to take a quick break, but when we come back, we're going to be talking about mammograms, ultrasounds. If you're like me, like I said, dense breast, you should follow up with an ultrasound. It gives you peace of mind, let's just say. You're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for Dr. Grover, please call us using the toll-free number 855-796-4475. We would love to hear from you, or check out that website, allhealthtv.com. You can watch videos from previous episodes or submit questions for our experts. We'll be right back. Stay tuned.
I was too young to get a mammogram, and I had no family history, and the lump was probably just nothing.
And I sat in that waiting room talking to women, and there were about 10 of us, and I casually joked with another woman, I can't believe that 1 in 8 women will be diagnosed in breast cancer. There are 10 of us in this room today.
Yo sabía que iba a regresar positivo.
I insisted on getting a biopsy. When I heard my grandmother was sick, I knew I had to take care of her more instead of her taking care of me.
I heard the 3 most horrific words anybody could ever hear. You have cancer.
My initial reaction when I was diagnosed is, I'm gonna die. Oh my goodness, I'm going to die, and I'm gonna leave my 2 young daughters behind.
I had a 4- and an 8-year-old and a husband to grow old with. And I didn't think that I thought my life was over.
Cuando tuve que llamar a mi mamá, ahí fue real.
If it comes back and you've done everything you can, at least you can turn to your boys and say, I did everything I could.
And so a couple weeks after my diagnosis, I had a double mastectomy.
They were giving me life-changing, devastating news, but at the same time, they were giving me a plan. Okay, this is what we have. This is how we're going to treat it.
I felt very blessed to be here in Miami and to have a network of doctors.
Cancer treatment is ugly. The way Baptist treats you as a person is beautiful.
When you finish radiation, you ring a bell. Pretty much the entire staff of MCI showed up.
I just knew in my gut that I was going to be okay.
Your dream team is out there.
Escogimos un team divino. Las siento como unas personas como amigas, más que doctores.
If I waited, I wouldn't be here today. Early detection is incredibly important. Know your body. Go into your doctor, get the mammogram, get checked.
I can't stress enough how important it is to be your own advocate.
Early detection saved my life. Embrace tomorrow.
Programe su mamografía hoy.
Abraza el mañana.
Schedule your mammogram today.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Priyanka Grover, breast imaging radiologist with Baptist Health South Florida. If you have a question for Dr. Grover, please give us a call using the toll-free number 855-796-4475. We would love to hear from you. So when it comes to screening for breast cancer, there are quite a few options out there. Let's take a look at one that's quite easy that we can do at home, and that's a self-breast exam. Take a look.
Hello, I'm Dr. Anaisis Ballesteros with Baptist Health Primary Care. When it comes to breast cancer, catching it early is the key for a positive outcome. For this reason, adult women are encouraged to perform breast self-exams at least once a month. Not only can self-exams help you to detect a lump or irregularity, it can also help you become familiar with how your breasts look and feel, so you can alert your healthcare professional if there are any changes. Contact your primary care physician for tips on how to perform a self-exam.
All right, so this is something I've always been, fascinated with. I don't do this, which I know I should. How do you do it? What's the best way to do it, and what are we searching for?
Okay.
And I know it's important, so I'm not trying to be, personal, but it is something that we should all be doing, and I think in the shower, that's the best place to do it?
I agree. So basically, I tell my patients that once a month, please do self-breast exam. In a shower is a good idea. Lying down may not be a bad idea. I usually recommend to do it after you have your periods because the breasts are less sore or engorged. So here's how and there are different styles, but here's how I advise my patients. We basically ask them to raise their hand above their head, use their hand on the other side, and completely try to press with their palm, try to press against the rib cage and rolling the breast, and also checking the lymph nodes. That way, when you don't try to palpate your breast like holding like this, it causes less false outcome. So basically, using a flat hand, rolling against the breast tissue, against the rib cage, it kind of gives you a better idea if there's any suspicious. I'm not saying that it's foolproof, and that's why there are other ways to, check the screening or to screen your breast. That's the mammogram, that's the ultrasound. But this helps. There are so many patients who come to me and say, "Listen, I felt a lump, and it was a new lump." And that's what you're feeling.
Yeah. Somebody once told me you're like searching for a pea, like a little pea, something hard.
It could be a small pea size. It could be bigger.
Okay.
Sometimes you cannot feel it, and it's still there may be a small mass which will be diagnosed on mammogram.
And do you stay, just because I think it's important for women to know how to do this, do you stay in this area here, or do you go maybe a little bit higher?
Absolutely. In the breast tissue, around it, in the axillary area or the armpit area, you should be examining your breast bilaterally and armpits at least every month.
And before we touch upon mammograms, and I know this can happen to a lot of ladies out there, and maybe you're like me where I'm very dense, when that cycle comes, you know, you find more things, if you will. So you get a little scared.
Correct.
Right?
Correct.
So what's your advice there?
Yeah.
Because sometimes, you know, I'll feel like these little lumps and I'll be like, and then I realize, well, maybe I'm ovulating or I'm about to get my cycle.
So right before you get your periods, there are some hormonal changes which causes your breast to become more tender, more sore, slightly more engorged. So I personally feel that it's better to do self-breast exam right after your period.
Right after the period. Okay, very good. So let's talk about mammogram guidelines, which is really important. A lot of people wonder, when should I start? When should I stop? So here are some guidelines that we're going to walk you through. Women at average risk, annual screening from age 40. Is that like the baseline, doctor?
Yeah. So if you have no family history of breast cancer, you don't have any previous biopsies with any abnormal results, or you don't have any history of ovarian cancer, then you are an average risk.
Okay.
Then you should start annual screening mammography at the age of 40.
Fantastic. And women at increased risk for breast cancer, obviously if your mother or grandmother had it, correct, doctor?
Or genetic mutation, or history of ovarian cancer, or any previous biopsy with a high-risk lesion, or any other high risk if your doctor has told you about.
Okay, it says starting by the age 30, but not before age 25, right? Why not?
That's actually a very young age for having radiation. So we actually try to balance the radiation so risk versus benefit. So I think at that young age, there is no need of mammogram. Breast ultrasound is a great tool. However, if we see a finding on the ultrasound, we may recommend a mammogram case-per-case basis, but ultrasound and MRI at that age are great screening tools.
Okay, fantastic. And then obviously yearly, regardless of age.
Correct.
Don't miss it.
So please, there have been confusing information on social media and on the web. I urge all women 40 and older to undergo screening mammogram once a year. There are amazing tools such as 3D mammography, also known as tomosynthesis, and adjunctive breast ultrasound to screen better if you have dead breast or other risk factors or other findings, but definitely please get your mammogram.
I do it every year on the same day because I'm too frightened not to do it. All right, so let's talk more about mammograms. There's something called tomosynthesis. I don't know if you've heard of it. Again, it's tomosynthesis. It's a breast cancer screening technology that allows doctors to see inside the breast more clearly. It's a 3D mammogram. I've never done this. A 3D mammogram that allows for better detection of tumors, especially, look at this, in dense breast tissue. Take a look.
3D uses a computer tomography to acquire images through the breast. So instead of, in the past, we used 2D. It's a single image, and you have the overlap of breast tissue. The 3D tomo has helped us diagnose early breast cancer, which it's what we want. We want to pick up the smallest as we can to save patients' life. It's better for the patient because the cancers are smaller when diagnosed, and it's just the evolution of the technology. Before we use analog, we have to process the image, and the quality wasn't too good. Now and then we pass to digital images, 2D, and now we're just getting better and using computer tomography. Bethesda Women's Health Center is committed to provide the best care for the patients. When they come here, they have the latest technology, and all our radiologists are fellowship trained. And when a patient comes here, they can feel confident they are having the best care.
So a lot of little points I want to bring up here. The 3D mammogram, 2D mammogram, doctor, which one would you recommend for women out there who are saying, well, which one should I get? And maybe there's a woman out there like me that has dense breasts. I've done the ultrasound. I haven't done the 3D. So it's just a lot. I mean, do we do them all? Do we do the mammogram? Do we do the ultrasound? Do we do the 2D? Do we do the 3D? It gets a little bit overwhelming. Your thoughts?
Great question. I totally get it.
It's too much. It's like, how many of these am I going to do?
Yes. So basically, here's the thing. We started with 2D mammography, digital 2D mammography. It's a great tool. In fatty breast, there are actually 4 types of breast: fatty breast, scattered glandular breast tissue, heterogeneously dense, and extremely dense. So now when we talk about dense breast, that means you have less fat in your breast and more glandular tissue, okay? In those cases especially, I feel, or we have had scientifically proven studies recommending use of 3D mammography, or called as tomosynthesis. It's a recent technique, and what it basically does is it makes the radiologist look through your breast tissue as if we are going over like through a book and just rolling the pages. It has helped me and many other colleagues of mine find cancers which were not easily visible on the 2D mammogram or the ultrasound. So I personally think it's a great tool. We at Baptist Outpatient Centers and Miami Cancer Institute offer 3D mammography to all our patients. And I think it has helped a lot. It's a very sensitive tool in cancer detection.
What about an MRI?
So breast MRI,
because I've heard of that one too.
Breast MRI is a very sensitive test, and we do not recommend it for just everybody. So breast MRI recommendation is basically for patients who have strong family history, and we didn't really see anything on mammogram or ultrasound, and they want to undergo supplemental screening, so then it's a great tool. In patients who have been diagnosed with breast cancer and we need to do pre-surgical planning or post-surgical changes, then we do breast MRI. In females who have history of high-risk lesions during breast biopsies, they can also undergo breast cancer screening by having breast MRIs. In young patients with BRCA gene mutations or high-risk patients, I think breast MRI is a great tool, but it's not for everybody.
Okay, very good. If recommended, then you should do it.
Absolutely.
A lot of people also are concerned about radiation, which I completely understand, and the effects of them. So let's take a look at this chart. The doctor's going to walk us through it and explain what we're looking at and how much radiation are we getting. Should we be concerned, doctor?
No. So I want to say this loud and clear. A lot of my patients come to me with concerns of radiation and refuse to get mammogram. And this is what I always tell. If you take a flight from here to Europe, you are exposing yourself to radiation slightly more than what a mammogram would give you. We undergo a lot of rules and regulations to minimize the radiation exposed to breast with a single mammogram. So as you can see in the graph, the mammogram is actually 0.5 millisieverts, which is the unit for radiation.
Yes.
Can I point to
I
that?
see it right there, 0.5.
Yeah. And then if you see that it's the same as a flight from London to New York. In fact, if anybody else gets a CT chest or abdomen or any other CT, it's a much higher dose, unfortunately. The surprising fact, which nobody really knows, is the annual background radiation we just get from living in the United States, there is actually much more than getting a mammogram.
Exactly. So the point is, loud and clear, like you said, it doesn't affect that much. It's worth getting the mammogram. Don't be concerned about the radiation.
No, it's life-saving tool.
Absolutely.
We should not ignore that.
All right, and I wanted to quickly talk about biopsies. We hear a lot about women when they get their mammograms or the MRI or the ultrasound or the, oh my gosh, 2D or 3D. There's just so many options out there, which is fantastic, by the way. Then there's sometimes something called a biopsy. What happens there?
So we recommend biopsies when there is an abnormality. The abnormality could be seen in the mammogram, could be seen on the ultrasound. Depending on where we see the abnormality more conspicuously, we offer the biopsy. It could be an ultrasound-guided biopsy, it could be a stereotactic, or stereotactic basically means that we do biopsy on the mammogram machine or the X-ray machine. It could be 2D versus 3D, depending on what we see. A biopsy, patients get scared, but it's a very simple, quick procedure. Patient is fully awake. Right. We give local anesthesia, and a very small needle is used to sample just the piece of tissue and sent to laboratory for pathology testing.
And just because you hear you're going to undergo a biopsy does not mean you have cancer.
So 80% of the times biopsies are negative.
80% of the time they are negative.
Yeah.
This is such great information because there's so many things that you hear.
It can be scary.
And it's overwhelming and women get scared, so.
Yeah, it could be scary, but I say the same thing. I have seen every age, varied age group patients getting diagnosed based only on the basis of mammography, sometimes 3D, sometimes 2D, sometimes ultrasound, and biopsy. My patients walk in being so afraid, and when they walk out, they're like, wow, that wasn't bad at all.
That wasn't bad at all.
Yeah.
And again, 80% negative, which is fantastic. All right,
Correct.
We're gonna take a quick break, and when we come back, we've got a fabulous person stepping into our studios, one of Dr. Grover's patients who had a double mastectomy just about a month ago. She's doing fantastic. She's gorgeous. Stay tuned to hear her story and how Dr. Grover found the cancer at an early stage, and that's the key. You're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for Dr. Grover, please call us using the toll-free number right there, 855-796-4475. Visit our website, allhealthtv.com, and we'll be right back.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
Each year, an estimated 12,000 women are diagnosed with cervical cancer. Thanks to improved screening and vaccination, cervical cancer is a highly preventable and treatable cancer. Early detection is key. Women should pay close attention to their cervical health by following these guidelines. Start testing at age 21. Women between ages 21 and 29 should have a Pap test done every 3 years. Women between the ages of 30 and 65 should have a Pap test plus an HPV test done every 5 years. A woman who has been vaccinated against HPV should still follow the screening recommendations for her age group. Your particular health history may dictate a different screening schedule for cervical cancer. Contact your primary care physician to talk about your history and schedule your next screening today.
CAR T-cell therapy is a revolutionary new treatment for cancer. Healthcare companies developing CAR T immunotherapy use Thermo Fisher's Dynabeads technology to isolate, activate, and expand T cells that have been genetically engineered to recognize and fight cancer cells.
We're taking the patient's own cells and enriching those cells to fight the cancer.
For more, go to thermofisher.com/CTS.
Cancer. We don't want to think about it, but I had to. Because you see, I was traveling, I was enjoying life, I was working. It was too long since my last PAP. When I was finally tested, we thought I might have cervical cancer. After worrying, no cancer. I was lucky. Women, please get a Pap test to check for cervical cancer and get the inside knowledge about gynecologic cancers for you and the people who care about you.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us is Dr. Priyanka Grover, breast imaging radiologist with Baptist Health South Florida. And we're now also joined by one of Dr. Grover's patients, Heather Parente. Is that correct?
That is correct.
Parente, welcome. Thank you so much for coming in.
Thank you.
So you basically just recently had a double mastectomy about a month ago?
I did, 3 weeks and 5 days ago. Wow.
How you doing? You look great.
I'm doing wonderful. I'm finally back to myself.
I love it. Well, let's first talk about how we got to this point.
Sure.
So were you, so many questions that come into my mind, but were you doing yearly mammograms?
I was.
Okay.
I had my my annual mammograms, and just like you, I had to have the ultrasounds as well.
Oh, you have dense breasts.
I do, I did.
Okay.
So in April, I went for my annual mammogram, and Dr. Grover came right into the room, and she said, Heather, you now have a 9-centimeter span of calcification, and she recommended that I have 2 biopsies at that time. So I did. I went and had the 2 biopsies, and at that point, they showed precancer, so we already had a concern. They asked me to do a recheck, so I went back to Dr. Grover in July. And when I went back in July, she said, Heather, I want to go deeper in the original biopsy spot, and there's one other location that I see. So Dr. Grover did my biopsies, and she found my cancer. I was diagnosed on August 7th, and the report showed that I had invasive ductal carcinoma.
So, okay, you said a lot in that 30 seconds right there.
I'm sure.
You were doing yearly mammograms, nothing was there. You were in the clear, doing some ultrasounds as well, because you
Yes.
have dense breasts. And within a year, this happens. And what they found, this calcification, can you explain what that is, doctor?
Sure. So calcifications are everywhere in our body. They are okay to be scattered in the breast tissue. However, when we see them grouped or clustered together, that could be an early sign of cancerous cells. In Heather's case, I did see a few clusters or groups of microcalcifications, and that concerned me. I believe you had a biopsy another place, and then, yeah, so she had a biopsy. Unfortunately, it somehow wasn't picked up. She did come back to us. I looked at her mammogram again, and there were certain signs in her mammogram which were very suspicious, and I did the biopsy, and that's how we found the cancer.
Okay, so Heather, when you hear those words, I mean, and forgive me for asking you this, and if you don't want to answer, I completely understand, but
I'm with you.
Were you scared?
I was terrified. I was terrified. But from the very beginning, when Dr. Grover walked into the door and said what she found and that I needed more biopsies, she pulled me right in her office and showed me the films, and she said, Heather, if it's anything, it's small and it's early. So I had comfort in those words.
Was it tough?
It was tough because I don't have family history, so I was navigating this for the first time in my family. But I relied on what she shared with me. It was early and it was small, and I just kept repeating those words in my head.
Absolutely. How important was family to you? Because I know you have a beautiful one.
I do. I'll be very honest with you. They got me through this. Both before the surgery and after, between my husband, my children, my mom washing my hair. The first 2 weeks after surgery was definitely difficult. But again, today's 3 weeks out and 5 days, and I'm back to myself, and by next week, I'm back to my normal routine, which includes going back to work.
She's a trooper.
I see a little bit of emotion.
Oh, without
coming
question.
through. And
Without question.
I empathize with it because I know how I feel when I go, and especially because I have these, I mean, my file says it's quite frightening, extremely, extremely, extremely dense. And you and I are kind of like in that same boat, and I always go in with that concern. Did you ever think that you'd hear those words?
Never.
Never, huh?
Never. Never. And I had the gene tests all done, and there were no indicators, nothing that would cause me to think that I'd be traveling on this journey.
She did not need chemo, correct, doctor?
No, she underwent mastectomy, bilateral, and thankfully she did not need radiation. I mean, radiation and chemo are great effective tools, but in her case, she did not need them. And I want to say, she, more than just what we offer as medical care, it's also emotional support.
It is.
And I'm so glad your family was able to provide it. And it's also your positive outlook towards everything.
We have some
which
pictures.
It's a holistic approach.
It is. And we have some pictures, I believe, that I'd like to show our viewers. And I think it's of her. There she is in the hospital.
That was right after the surgery. Once I got up to my room, I was thrilled it was behind me.
And look at your smile right there.
Look at that. It's powerful.
It's contagious, to be honest with you.
Yeah.
I see.
That's my husband. That was in the pre-op room. He's been with me every step of the way.
Oh, that's fantastic. Do you think your attitude was really important? Because some women don't take it the way you did.
I definitely think so. And there were cards, there were flowers, there were meals. Like the mailbox was always full of something, and it just meant the world to me.
Doctor, we said it's a support system. It's holistic, like you said. It's a fight that one has.
And I feel it's not just about a doctor-patient, it's a team.
It is.
We are a team. and we all fight together.
Do you have faith?
Oh, without question. Without question.
What would you say to women out there today who maybe are waiting for a biopsy, or maybe yesterday got the news that they're diagnosed?
I will tell you that I share my story with everyone, because the annual checkups, the procedures, the follow-up procedures that you're asked to do, they are imperative. I did everything that I was supposed to do. I did all my follow-ups right away. And because of that, my cancer was caught, and it was caught at the size of 1 millimeter. When they removed all the breast tissue and they had to remove lymph nodes, there was nothing else there. So like Dr. Grover said, it was early and it was small, and 3 weeks and 5 days later, it's all behind me. No chemotherapy, no radiation. So stick to your plan, do your follow-up checkups, and it'll be behind you too.
When you woke up and you were in the recovery room, do you still remember the doctor, your husband, everybody saying, it's fine, it's over?
I do. My first question was, tell me about my lymph nodes. And I was told that they were 100% clean.
Great.
So that was the best 2 seconds of my life.
And that's the whole point of mammography, that we want to catch cancer before it spreads to lymph nodes or gets advanced or gets to any other level.
That's right. We're about to end our show, but we do want to show you the guidelines real quick in case you just started joining the Health Channel. You know, women at average risk, doctor, we said start at age 40. Women at increased risk, age 30, but not before age 25. And a couple things that we mentioned, don't worry about the radiation, right, doctor?
It's small, it's very low.
Exactly. And get a yearly checkup, mammogram, 3D, 2D, whichever one you opt for, listen to your doctor.
Correct. Please talk to your doctor and follow the guidelines.
All right. I want to end with you, Heather, because not only are you fantastic, you're beautiful, and you're just such an inspiration.
Thank you.
Any final words?
Listen to your doctors. Do your follow-ups so that you too can get past any diagnosis that you might have, because you can do it.
Any celebration of life right now that you're going to do soon with your hubby?
Yes, we're looking to go away. The first question he asked the doctor was, can I fly? And the answer was yes. So we look forward to a trip very soon.
Good.
Yay.
Any place in mind?
New York. We like to travel. We like to travel to New
Broadway.
York.
Place,
Yes,
great place
exactly.
to be.
Start spreading the news.
Exactly. Perfect. Thank you so much.
Good luck to you. Thank you so much. God bless you, doctor. Thank you for all the great information. And I'm going to look into that. Look at the hug. I'm going to look into that 3D mammogram. All right. Absolutely. Be sure to join us next time on the Health Channel, All Health All the Time on South Florida PBS. Maybe I'll take the cameras in there and everything so everybody can see how it works. Follow us on Facebook and Twitter. Well, I'll be covered up, of course. And they're like, she's so funny. At All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel. After 50, anything goes, right? Absolutely. All right, you can submit questions for our website as well. It's allhealthtv.com. There it is. Any questions, our doctors will get back to you. I'm Olga Villaverde. It is breast.
I was too young to get a mammogram, and I had no family history, and the lump was probably just nothing.
And I sat in that waiting room talking to women, and there were about 10 of us, and I casually joked with another woman, I can't believe that 1 in 8 women will be diagnosed in breast cancer. There are 10 of us in this room today.
Yo sabía que iba a regresar positivo.
I insisted on getting a biopsy. When I heard my grandmother was sick, I knew I had to take care of her more instead of her taking care of me.
I heard the 3 most horrific words anybody could ever hear. You have cancer.
My initial reaction when I was diagnosed is, I'm gonna die. Oh my goodness, I'm going to die, and I'm gonna leave my 2 young daughters behind.
I had a 4 and an 8-year-old and a husband to grow old with. And I didn't think that I thought my life was over.
Cuando tuve que llamar a mi mamá, ahí fue real.
If it comes back and you've done everything you can, at least you can turn to your boys and say, I did everything I could.
And so a couple weeks after my diagnosis, I had a double mastectomy.
They were giving me life-changing, devastating news, but at the same time, they were giving me a plan. Okay, this is what we have, this is how we're going to treat it.
I felt very blessed to be here in Miami and to have a network of doctors.
Cancer treatment is ugly. The way Baptist treats you as a person is beautiful.
When you finish radiation, you ring a bell. Pretty much the entire staff of MCI showed up.
I just knew in my gut that I was going to be okay.
Your dream team is out there.
Escogimos un team divino. Las siento como unas personas como amigas, más que doctores.
If I waited, I wouldn't be here today. Early detection is incredibly important. Know your body. Go into your doctor, get the mammogram, get checked.
I can't stress enough how important it is to be your own advocate.
Early detection saved my life. Embrace tomorrow.
Programe su mamografía hoy.
Abraza el mañana.
Schedule your mammogram today.
Many websites selling medication may look professional and legitimate, but the vast majority of sites selling prescription drugs are doing so illegally. Criminals use websites to sell counterfeit medications that may contain life-threatening toxins. Dot Pharmacy is a website verification program that helps you identify safe and trustworthy online pharmacies. Purchasing medicine online can be safe and easy. Just look for pharmacy to the right of the dot in website addresses.
Don't just worry about your health problem. Ask an expert. An answer to your health question is as close as your phone. Call 855-796-4475. The Health Channel, America's first all-health, all-the-time TV channel. Fully qualified health experts, doctors, specialists can answer your health questions. The Health Channel, all health, all the time. Call 855-796-4475.
Our goal in this project is to find ways that we can reliably measure fit in real time on people in the workplace while wearing respirators.
When a worker is introduced to the respirator in the workplace, they are given a yearly fit test. And this fit test not only ensures that the respirator fits them appropriately, but they are also taught how to don it properly. The problem with this annual fit test, however, is that it is only once a year. And research has shown that within 2 weeks, most people start to forget how to appropriately don a respirator.
The current test is what's called an aerosol penetration test. And it uses this device over here, and it attaches to your respirator through a grommet you have to add. So basically you can't use that respirator. It's only for the test.
Current test methods use something called a porticount. Porticount takes the ratio or the count of particles inside the mask and compares them to the count of particles outside the mask. However, this can only be done by destroying the mask. Using a real-time method allows the worker to don their mask in the field, in the workplace, check for any leaks or inappropriate donning, fix the donning if needed, and then allow the worker to go to work and continue their job.
The question here is, would an approach that allows us to do it in real time give us the same information we get from a laboratory test, except it would be associated with you wearing the respirator and going about your normal job?
The current status of our project is comparing several different methods to check real time. Some of the methods we're using are infrared imaging, ultrasound, and pressure within the mask.
What we're doing now is comparing those methods to the current methods used for leakage and see how well they can predict that.
So far, we know that using the infrared imaging, we can detect leaks around the respirator seal. We know that using ultrasound, we can detect the same leaks. And so far, we found that both ultrasound and infrared do correlate to the fit of the mask. And we haven't gone too much into analyzing the pressure data yet, but from what we have, the pressure also correlates with the IR and the ultrasound fit.
We want to identify with the data we get where workers may not be protected. And we may find that, we may not, but we don't know until we measure it. So that's the goal here, is to give workers the information that can be used to understand where they won't be protected and make appropriate adjustments to rectify that.
If a worker dons a respirator daily, they are more likely to know how to properly don the respirator because they are using it every day. Of course, being able to check the fit immediately would be very beneficial to them. However, the workers that only use them in emergency situations, which might be once a year, once every 2 years, are going to be the more targeted audience for this because they don't wear it all the time. They don't necessarily remember the proper donning methods. So being able to put it on and have them check the fit to make sure they're properly protected will protect them more in the emergency situation.
Healthcare expressed an interest in having a device that would tell them just the information that we hope to get from this project. And if we're successful in identifying an approach and then taking that into a device that will actually work, that will allow some useful information to get to people that use these devices in the field.
There is no one particular program that this work will support. This will benefit every single respirator user once it's complete. The overall mission of NIOSH is to ensure that all workers are safe and can safely do their jobs and go home at the end of the day. Providing something that can test the fit of the respirator in real time will help ensure that NIOSH fulfills its mission and improves respirator fit going forward.
When it comes to sexual violence, it's important to know the facts. But there are just a few other things you should know. Sexual violence includes rape and any other unwanted sexual contact or experience. About 1 in 3 women and 1 in 6 men have experienced sexual violence in the form of physical contact at some point in their lives. Violence starts early. Before the age of 18, 8.5 million women first experienced rape. Victims of sexual violence can experience depression, anxiety, and suicidal thoughts. Sexual violence impacts everyone. Its effects ripple through families, neighborhoods, and workplaces. But we all play a role in its prevention. Public health, businesses, schools, communities, and you can work together to stop sexual violence from happening in the first place.
I was one of those guys just afraid of the doctor. So I wasn't going for a regular checkup. But I had a high blood pressure condition that I wasn't aware of. Just blindsided me. I go to work in the evening. So prior to work, I usually go about an hour at the gym before I go to work. Went in a little bit earlier, did cardio, worked out, and then at the end of my workout, went to play some basketball. And all of a sudden, I just felt dizzy. And I started holding on to the wall, holding on to my friends. He said, lift your left hands. And I barely could move my left hands. So he said, immediately call 911. His guy having a stroke. And I remember the paramedics coming by and they said, they ain't able to save this guy. We have to airlift him immediately to Grady Hospital. I mean, it was a blood clot to the brain. It was a major, major stroke. So they had to go through my body, up in my brain, and take out the blood clot.
The most common type of stroke is when an artery is blocked. When that artery is blocked, then blood flow can't get to the brain, and that part of the brain stops working. If that part of the brain stops working, then you have symptoms like weakness on one side of the body or difficulty speaking.
Stroke is the 5th leading cause of death for all Americans, including African Americans, but African Americans are twice as likely to have a stroke compared to whites.
Grady was really good to take good care of me. Even today, they still do. They follow up with me after the hospital and make sure everything was okay. Hardest time I had, changing my diet. I think it was the hardest time. I mean, like I said, after 40 years of eating a certain way, all of a sudden to change that. But I think it's a change for life. Prior to my stroke, I didn't eat a lot of fruits and vegetables at all. Today, 2 to 4 pieces of fruits a day and vegetables 2 to 3 times a day. My kids, they were happy when I came home, and when they see me exercising and trying to eat right, you know, they encouraged me, and I try to get them encouraged also so we can do this together.
We want people to know that stroke is preventable and treatable, and there is hope. There are things you can do. You can work with your doctor to reduce your risk, and regularly checking your blood pressure is important.
I keep a log of my blood pressure, and it's been controlled. This whole year it hasn't gone over 120. I want to be a spokesperson for this, to be honest with you. Well, I want to say, first thing is, please, please, please go to the doctor. Get yourself checked first. It's very important. Get yourself checked, see where you are. And if you have to go on medication, do it. All my friends, I mean, I tell them every single day, listen, man, you got to change your diet 100%. Start with your diet first, and then just gradually start walking, start getting this exercise. So all my friends, you know, I'm an advocate of being healthy and eating right now. And I think what motivates me the most is my 4 kids. I want to be able to see them grow up, go to college, you know, have their own family. And me passing down this eating right and the healthy lifestyle, and they're passing that on to their kids. So I think that's my biggest motivation, just watching my kids grow up and showing a good example.
If you're not paying attention to your bank's interest rate, you might be getting shortchanged.
The average interest rate on savings accounts is 0.08%, but some of the largest financial institutions pay as little as 0.01%.
Online banks like Ally have the highest rates of return at a whopping 1.90%.
As an online bank with no physical branches, we're able to pass that savings back to our customers through consistently competitive rates.
On an average $5,000 savings account, that could mean the difference between earning 50 cents or $100. For more, go to ally.com.
I'm a retired staff sergeant with the U.S. Army. We were on a training mission. We hit the ground. I was in the hospital for 20 months recovering. Before Wounded Warrior Project, my life was not much of anything. I rarely left the house. Wounded Warrior Project has helped me really meet with other guys, other warriors, other families. I have a second chance because of your help, and I have such debt to you for that. Thank you so much.
The Health Channel is made possible by the continued leadership and generous support of the Eunice Joyce Gardner Charitable Foundation and the Kessler Family Foundation.
Welcome to the Health Channel, all health all the time. I'm Olga Villaverde. We're coming to you from the Baptist Health South Florida studios in Coral Gables. And once again, we're going to talk about a fascinating new trend in injury recovery with Dr. Michael Swartzen, sports medicine physician from Miami Orthopedics and Sports Medicine Institute. Welcome back.
Thank you, Olga. Thank you for having me
Thanks
again.
for joining us again. Great conversation we had last time with this doctor, and great conversation we're going to have today as well. And today we're focusing on stem cell therapy. Doctor, what great promise this is showing, isn't it?
Right now, this is the most promising item we have to try and help in orthopedics, to try and get people moving, to try and get their pain down, to try and have them avoid surgery.
And in many different types of conditions, especially in orthopedics, correct?
Correct, because you have your new injuries. You have your injuries that happened a little while ago that haven't gotten better. You have your overuse, and then you have your typical degenerative problems like arthritis.
And I don't want to use the phrase from this beautiful movie, but it really is a whole new world.
Yeah, right now, I mean, before, if you went, let's say 20 years ago, before we considered doing any of these treatments, if you went, you really had two choices. You could go to physical therapy and let time and some effort work on it, or you could have surgery. And those were it.
That's it. But now we have other options, and we're going to talk about all these options today and the benefits of stem cells. But first, doctor, I want to break it down. Which let's just start at the beginning. You know,
Okay.
It's not even stem cells. That's a little outdated. I'm reading here the more accurate term is regenerative therapies. What's the difference and why?
So stem cell is concerned with one specific type of cell that's trying to do one specific job. When we're trying to talk about in sports medicine orthopedics, we use the term orthobiologic. And we use that term ortho for orthopedics and biologic because these cells or plasma or growth factors or proteins, whatever we're using, are biologic in nature. They're not made by a pharmaceutical company. They're not a drug. They're from a natural source. And we're using them for orthopedic means, which stem cells could be used for many other things, but I'm not an expert in those topics. I work with them mainly for musculoskeletal conditions. And so what we want to do is regenerate, but really what we call it specifically in orthopedics and sports medicine is orthobiologics, is a little bit more inclusive of a term.
And we have a story of one of your patients, fabulous story here. He's smiling already. A golfer named David who has successfully used stem cells. Let's take a look at his story.
David is like a very typical patient that we see here. Active and likes to do things.
I've been golfing for 15 years. One day I may be good at it.
Unfortunately, he has degeneration in his knee, which is arthritis. He came to us for help with his pain.
It was really debilitating. And we had done, prior years, we did the Synvis shot and we did the cortisone shots. And everything worked fine for 4 or 5 years, I guess. And then it just got unbearable.
We were at the point where he would either have to go to surgery, which is something he didn't want to do, or try something else. We've had some breakthroughs in treatment. We try and use things that are normally used by the body and try and get them to do good work where we want them. So in David's case, it's the cartilage damage in his knee. We want to put something in there that's either going to significantly slow down the arthritis or possibly reverse it.
I said, any downside to it? And said, no. I said, well, let's give it a shot.
David actually ended up having 2 types of injections combined. He had platelet-rich plasma and stem cell therapy, the PRP are the cells that help build and repair, and the stem cells are the cells that differentiate into all the other cells in your body.
It wasn't instantaneous. It took a few weeks, and it just started gradually getting better, and the pain level went from a 7 to 8 to maybe 4 to a 5, and I got a second shot, and that knocked the pain down to maybe 1 to 2.
When I talked to him a few months later, and I just followed up because he hadn't come back, I just called him. I said, David, how you doing? He says, you know, my elbow hurts. And I was like, your elbow, what about your knee? He's like, no, knee doesn't bother me.
Dr. Schwartzman and the rest of the staff at the Miami Orthopedics and Sports Medicine Institute are just phenomenal. They're very, very knowledgeable. There's not a question that goes unanswered. He explains everything. And I've told anybody, you know, come here, give it a shot, you know, not necessarily just for the stem cell, but as a doctor, he's terrific.
That's what I'm here to do, is to get him back to doing what he wants to do.
And he's back doing what he wants to do, right?
Last I heard, I haven't heard from him in a while, so he must be doing well.
Well, that was funny, the elbow. What about the knee? You know, and the knee's doing great, all because of stem cells.
Yeah. So
let's talk about stem cells and where they come from.
So we all have these cells in our body that are like, in Spanish they use the term mother cell.
Okay.
Right, and it's a good way to look at it because you have, in your bloodstream here, you can see the hematopoietic stem cell. What we generally talk about with stem cell therapy is the mesenchymal stem cell. There are some that circulate through your bloodstream, but most of them actually sit kind of here in the bone marrow. They can turn into anything. So their daughter cells can turn into cartilage, can turn into tendon. They can make anything, organs, so on and so forth. So when we use the term stem cell therapy, we're trying to bring cells in that can repair the problem that you have. That's the ultimate goal, is that your body's natural process for creating things is what's used to repair the problem that you have.
And when someone hears something like that, including me, they think, wow, this is just amazing where we are today, because we didn't hear about this way back when, right?
No, we had no idea how to harness this. We're still, I would say, in the investigative stage of learning what can stem cells do, how effective are they? Is there a specific recipe that we need to use that would be different per person, per injury, whether it's arthritis or whether it's a new injury? You know, when does it work? When does it not work?
Still learning along the way. Still learning. But it's not just stem cells, right, doctor? Because in David, right? Yes. In David's story, you and he mentioned PRP, and that I believe is platelet-rich plasma. I jotted it down there. So I took my little notes there. What is that, doctor, and how is it administered?
So PRP is probably the most common thing we do as far as the orthobiologic treatment. What we do is we take blood from your vein. It's a very, very similar mechanism for how the doctor draws blood from you, doing regular labs for your physical. We use that blood in a centrifuge and we spin it, and we take out the red blood cells and white blood cells, and we leave basically the plasma. The plasma has your platelets. The platelets are what help control growth factors. Those growth factors are used for repairing. It was a process called angiogenesis, which is just trying to start the repair process, the rebuilding, the rejuvenation process.
And can I ask you, how did the stem cell therapy actually develop in orthopedics? Because it's fascinating how it got there. And when did it become appropriate treatment to help the body heal after an injury? Two big questions there.
Right, two big questions. I think the earliest research I've seen has been from 1990 to 1998, when people were using autologous blood serum. So they were just drawing blood and putting the blood into the area. So we would draw your own blood, as opposed to just specifically using the plasma part. Because really the red blood cells and white blood cells aren't needed for the most part in orthopedics. How it's come from there is a very good question. Really, it's just been grown and grown, and as I mentioned, it's investigatory. So insurances typically don't cover this procedure. It's something that you have to pay out of your own pocket, and the reason is because we're still trying to discover if this works. Now, while we're investigating, people are getting very good outcomes, so they're feeling better, they have less pain, they're able to do more with their life.
Fantastic.
And so the quality of life and the activities they're able to do is better, and people don't want to wait. We were waiting. When I first got this job 5 years ago, we weren't really doing it. David was actually one of the first patients we had 3 years ago.
Really?
And the reason we weren't doing it is because we're very conservative practice at the Miami Orthopedics and Sports Medicine Institute.
Cautious.
We like very strong indications to do procedures. We like using evidence-based medicine so that the patients get the quality care. But when you start hearing about other physicians like myself doing it and having successes,
like David,
and you start losing patients because they're going to Colorado or New York and getting the treatment that you could do, and they're just doing it elsewhere,
right,
and they're having good results, it makes you start thinking perhaps we should offer this. And so that's what we started doing. And it kind of brings up an important point, that the conversation that I had with David and with people that come into my office is that this is not a miracle cure. This is a product that we're experimenting, we're investigating. If you look at the research, the side effects are zero. This is your own stuff.
Exactly.
So you don't need to worry about things that you might otherwise, like with surgery. Bad things can happen. Very, very small percentage, but it could. You could end up worse. With these procedures, you're not going to be worse. You're not going to have anything bad happen. The worst case is it doesn't work. And so then it becomes more of a money problem in the budget. And so if this is something that's important to you and you're willing to put the time and the money in, that's the conversation you have. What are your other alternatives? Because if there is a very good surgery that would work for you, perhaps that's your best option. Perhaps you want to try physical therapy first and see if that works. And if that doesn't work, then you try something like PRP or stem cells. I think it's very appropriate. There's no point in trying this first all the time.
Right. And it seems to me here you have a lot of benefits instead of risks. which we always hear you have to balance those two. Great stuff, Doctor. Up next, we are going to take a look at what stem cells can do in the body and why they're being used as an alternative, like the doctor said, to surgery. Stay with us. Remember, this is the Health Channel. All health, all the time. Don't forget you can submit your questions to the experts right there, allhealthallthetime.com, and we'll be right back. Stay with us.
Emily is thinking about taking a dietary supplement. She knows she should try to get her vitamins and minerals from the food she eats, but she doesn't always have the chance to eat right. And with more than 50,000 dietary supplements on the market, like a lot of other people, Emily has questions, like how much vitamin A is good for you and how much is too much. If something's natural, doesn't it mean it's safe? Can folic acid prevent birth defects? Should we be taking calcium and vitamin D supplements? Luckily, there's a place everyone can go for answers. It's the website of the Office of Dietary Supplements. We're part of the National Institutes of Health, and since 1995, we've been conducting, funding, and evaluating research that we use to educate the public, giving Emily plenty of information she can share and discuss with her healthcare providers. We're ODS, for what you need to know about dietary supplements.
Dr. Lambert invited us to come to this program called Day of Smiles to do another surgery for my son's lip. He was born with a cleft in his lip.
This is our 16th year, and we deal with kids under 18, although we've done some people beyond that. And it started off with cleft lips, and then it segued into congenital hand problems, burns, tumors. It's really expanded into a wonderful program. But it is a totally free program, and Baptist Children's Hospital provides everything. The doctors donate their time, the staff donates their time. It's all done. There is no cost, and we want to emphasize that so that next year we have a whole bunch of people signing up.
They're opening a door where, your child's able to grow and to feel better about themselves, and be able to go to school and be around the other kids and not be ashamed. So it's something that you don't want to turn your back on. You want to do it.
Welcome back to the Health Channel, All Health, All the Time. I'm Olga Villaverde, and I'm here with Dr. Michael Swartzen, sports medicine physician from Miami Orthopedics and Sports Medicine Institute. And we're talking about regenerative medicine and stem cells and PRP, which is platelet-rich plasma therapy.
Right.
All right, so that term, regenerative medicine, is a specific area of treatment, correct, doctor?
Right. When you have people that come in with an injury, a lot of them are more wear and tear.
Mm-hmm.
Okay, so we don't want to say old age because it can happen really at any age depending on the injury.
How young has it happened in terms of your practice?
We have people in their 30s getting total knee and total hip replacements already.
Wow.
Because of military injuries, car crashes, athletic injuries.
Trauma.
Mm-hmm. Correct. And it's sad because otherwise their joint may have lasted 60, 70, 80 years, their lifetime.
Sure.
And sometimes it doesn't. So really what we're trying to do, if we can, the goal is to reverse the process. We're not there yet. I'm certainly not saying that any of these treatments are a cure for arthritis, but right now we don't have a cure. And our only options are either you live with it or you have surgery to replace the joint. And sometimes neither one are the most appealing process to people because of that risk-benefit ratio.
Sure.
So if we have something that might work, or something that will work for a short period of time, let's say a year, some people are very, very interested, especially if you're in your early 60s and you want to make it to retirement and you want something to help keep you going before you retire. Great. Or maybe you're in retirement and you want to actually enjoy your retirement before you go ahead and get your knee or your hip replaced. This is an option for you to look at.
Lots of things to discuss with your doctor, obviously.
Yes.
You have a 3D animation. You were talking about arthritis, and I actually wanted to take it if possible. Do we have that there where we can show our viewers? He's actually searching for it right now, and it's a good description of the arthritis and what it can do. So let's see if we could take that right now. Ed, thank you so much. That's our director, always on standby for me. And doctor, what are we seeing here?
So you're looking here, the white represents your bone. So this is your femur, and this is your tibia. And the space between the two bones is the knee joint. Now, between the two every bone joint surface is covered with cartilage. That's represented by this white. What you see here in red is where the cartilage has worn down. And so once the cartilage starts wearing down, the space between the bones narrows, and then the bones start making contact with each other. In that case, the bone gets stressed. You feel that stress is pain. Because the bone feels the stress, it actually grows more bone, which is where you get osteophytes or bone spurs. People get bone spurs that are so large that their knees sometimes can't even bend or straighten out completely.
Oh, how painful.
It's very painful. It's very painful. And so what happens is your body comes in, sees the damage in the cartilage, and actually, instead of repairing it, causes more destruction. Right, so you'll see people with arthritis, they go on a cruise or they go hiking, and then all of a sudden their knee will really swell up, they'll be in pain. It's not a good sign.
It's not.
It's not. It's a problem.
And how would stem cells,
right.
could, again, because I'm already hearing from you that it's not a guarantee, but could it help this situation on a scale of 1 to 10? How bad is this, by the way?
This is very bad.
This is a bad. Let's say this is a 10.
This is a 7 or an 8.
Okay.
There's barely any cartilage left.
So any hope with stem cells here, doctor?
The more severe the case, the less of a chance of something like this working, like PRP or stem cells. What we know is going on and what will help with these treatments is the environment in the knee. So right now you have one of inflammation and pain and destruction. When we put in the cells like the PRP or the stem cells, what we're trying to do is change that environment from one of, like I said, destruction to one of calmness, hopefully rejuvenation. But essentially, we're trying to modulate all that biochemistry in there and turn off the things that are causing the destruction and turn on the things that would repair.
We do have a graphic of some of the highlights, or some of the things, let's say, that stem cells can do. So let's look at these and walk me through them, doctor. Let's see the first one. If we could take that, Ed, thank you. Against Ed on standby, always ready for me. What can stem cells do? Support repair of damaged tissue, which you touched upon, doctor?
Correct. Right. So if you have a tear in a soft tissue, ordinarily your body would form some scar tissue. It may not form very good scar tissue. Something like PRP or stem cell may aid it in forming the proper tissue. Plus, it may do that faster.
Okay, reduce inflammation at times?
Correct. There's a lot of interleukins. These are just types of proteins in biochemistry, like how you get a fever. There are things that get released to cause a fever.
Okay.
Same thing, there are cells that cause inflammation in your knee, and PRP and stem cells have been known to reduce that.
May promote soft tissue reconstruction.
Correct. These are not necessarily the worker bees. These are more the managers, the on-site contractors. And so what we hope is that they come and they bring with them the power to secrete all these growth factors to promote the repair.
Slow healing process?
It actually speeds up the healing process.
Okay.
For almost everything, there are some studies that actually show that stem cells can improve fracture healing in bone, healing of soft tissue like hamstrings in those injuries, and then if you have a bad case of tennis elbow, stem cells or PRP are a very good source of treatment.
Does the patient need any invasive procedure to harvest their own stem cells? And what are we looking at here, doctor?
So that looks more like a donated amniotic or umbilical cell donation. So we do use some of that treatment. I think we were kind of talking about it earlier.
We were. Actually, before we started the show, I had informed the doctor about 16 years ago, which is a long time ago, and it wasn't very popular back then. I personally wasn't aware of it. They came in and they asked me to save the umbilical cord for my daughter and for future. Again, it was a confusing time for me. I wasn't up to date, and I said no. It's becoming more popular. But that umbilical cord today, a lot of moms, when they give birth, are now saving it.
Right.
For many reasons.
For many reasons. And most chief of which is for that kid to have insurance against some kind of blood bone marrow disorder. That's not specifically what we're talking about today, obviously with orthobiologic type treatment. The theory is the same. We're trying to take from the main source of all growth that form the human being. Instead of, let's say, you storing it for your daughter's sake, perhaps you can donate it or even sell it to a tissue bank, and someone else could use it for their benefit.
Which is what we were seeing there in that picture.
Which is what it looked like we were seeing, correct. It looked like it was a cryopreserved amount of fluid that we could then unfreeze and then put in the area that you needed, help.
We have to take a break in just a moment, but I did want to ask you real quick. We talked about how insurance doesn't cover it, and I was wondering if it's showing so much promise, and in many cases, like David, we have success. Why aren't, I don't know if you can answer this, but why aren't they covering it, and how expensive is this?
So first, for them to cover it, you want the FDA to have an indication for it.
Got it.
So that's the biggest thing. The FDA isn't saying these, for the most part, for orthobiologics, it's unsafe. They're just saying that right now there's no specific indication, which means that one of the companies that generates these kits needs to show unequivocally that this treatment is better than another treatment that's currently available. And those studies are ongoing. We'll get there.
We will.
But for right now, the FDA says this is an investigatory material. And so insurance companies are not going to be quick to pay for things at all. In
Yes,
general.
we know that.
So that was the first part. And then
how
the cost,
expensive is it?
The PRP is significantly cheaper. It's usually in the order of hundreds.
Okay.
The stem cells is a lot more involved. The umbilical or amniotic tissue you have to buy from a tissue bank like an organ, and so those are generally in the thousands.
Oh, wow. Okay, so we're talking a substantial amount of money.
Substantial amount of money.
But, David's case, here it was, very much worth it. All right, so great discussion here, Doctor. Still ahead, we're going to see how professional athletes use regenerative therapies and if it can help to heal these situations, these therapies that can be used to help all of us, because that's what we really want to talk about, you and me. So don't miss that. Please visit our website, allhealthallthetime.com, to submit questions to the experts and to find out more about the Health Channel in South Florida, PBS. We'll be right back.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
A concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
Overuse and misuse of antibiotics promotes the development of antibiotic-resistant bacteria. Every time a person takes antibiotics, sensitive bacteria, bacteria that antibiotics can still kill, are wiped out. But resistant bacteria are left to grow and multiply. Though antibiotics are completely ineffective against viral infections, like the common cold, flu, most sore throats, bronchitis, and many sinus and ear infections, they are still commonly and wrongly prescribed. Smart use of our antibiotics is key to controlling the growth of resistance. It's estimated that of those patients who visit an outpatient provider in the United States, over half of antibiotics prescribed are inappropriate.
Migraines are pulsating headaches that often occur on one side of the head. If you suffer from migraines, you're familiar with the throbbing, one-sided pain that makes you sensitive to light and noise and causes nausea or vomiting. Some home remedies for migraine pain include changing your diet, monitoring triggers, scalp massages, using an ice pack, anti-inflammatory herbs like peppermint or chamomile, and staying hydrated. Contact your primary care physician about treatment options available to you today.
Welcome back to the Health Channel. All health, all the time. I'm Olga Villaverde, and I'm here with Dr. Michael Swartzen, sports medicine physician from Miami Orthopedics and Sports Medicine Institute. And of course, we're talking about regenerative medicine, which includes stem cells. Doctor, before we talk about the future and athletes, I can see a lot of our viewers probably going to Google and now looking up things, which I've learned maybe sometimes not even to do anymore. But let's say they're going into Google and they're going into stem cells, and you see a lot of, I just did it on my phone, you see a lot of like spa, anti-aging, and other types of clinics, and we see a lot of cosmetic purposes, and this is a danger sometimes where our viewers really need to be careful, right?
Right, so today we're talking mainly about the orthobiologic or the orthopedic musculoskeletal applications of these rejuvenation treatments. I think I tried to make it clear earlier that these treatments are safe, but they're not covered by insurance. There's no clear indication by the government, and so it's investigatory, and so this is a discussion to be had on a case-by-case basis. So for example, if I see about 100 patients a week, I probably do about 5 of these.
Okay.
So maybe 5% of my patients are stem cell regenerative treatment. Whereas in some of these clinics that you've kind of mentioned, 100% of their patients receive these kind of treatments. And so when you walk in, generally they say, this is the cure for you. Just sign on the dotted line and we'll take care of it.
And give us your cash.
Correct.
And sometimes that's
dangerous.
not, it's very
dangerous.
And tell us why we have to be careful of doing something like that.
Well,
because we have them here in Florida.
Right, we have them here. One, generally those clinics will charge you a lot of money.
Yes.
2, if it's a cash-only place, that's all they do. There's really no regulation of them whatsoever. I'm credentialed by the hospitals that I work at. They look into my training, they look into my experience. I'm credentialed by insurance carriers, Medicare. They look at my training. They've agreed that I know what I'm doing, and I can treat people. When you just open up your own practice and you don't have to ask anyone's permission, it can open the door to slightly unethical or an undertrained person doing these procedures that may not even be a physician. And so it just becomes very lucrative to promise something to patients, and you can try and provide it. And again, this is a very small minority.
It is, but it's good to note. A very small minority,
but they are causing a lot of, I would say, damage to our reputation.
Bad images.
Yeah.
Bad images to something that is supposed to be hopefully promising.
Right.
And very, very, very promising for even the future. So just do your homework.
Do your homework.
That's what we're trying to say.
I would say that we're talking again about orthopedics, but I've heard of PRP being used in dermatological issues, even in hair loss, and people are having good success. I can't comment specifically on that. So there are ways why a spa would use PRP or an anti-aging clinic would use PRP safely and possibly effectively. But there are other places that maybe for Parkinson's disease or heart failure or blindness that I don't think there's really any good data for just yet. So again, promise, but as long as you, the patient, understands that it's a little bit wishful thinking at the moment and not any real data, that you may be putting yourself at risk. It's certainly with these clinics, they charge much higher than most, so you're risked kind of getting scammed.
Absolutely, and I'm glad you brought that up. So just do your homework and be careful. Doctor, we've heard of stem cells and their, regenerative therapies, and they have the potential to grow new tissue and cure things like spinal cord injuries. Now, I've been to the Miami Project many times and spoken to Mark Bonacani, who is obviously the president, and his father, Nick. Well, you're a football. You love football. He loves the Dolphins. That's what we talked about in our last segment when he was here. They've been years and years doing studies on spinal cord injuries. Is there promise there? Him along with Dr. Green, very famous doctor there, really spent
a traumatic injury like a spinal cord injury. Why can't those just reconnect and then you'd be able to walk again?
Of course.
It seems simple. Logical. But 30 years, we're still working on it. And so if stem cell therapy is able to get these nerves to recover faster and make recovery possible, I'm all for it.
Yes.
And I wish them the best success.
We can only hope, and they say it's going to happen, so we have our fingers crossed for them as well. You were talking earlier about someone, or you said 5 out of 100. Was that the right number? I jotted it down somewhere. Does that mean that maybe not everyone is a candidate for this kind of treatment, doctor?
So treatments that are tried and true are generally the best way to go. And so if you have very bad hip arthritis, a hip replacement is a really good procedure. The outcomes are excellent. The newer techniques aren't cutting the muscle. Some of our doctors are having people use it as an outpatient procedure. You're in and you're out the same day. So it's not like it used to be. It's generally going to last you your entire lifetime, and it is a very effective, permanent solution.